Hi, everyone. Thank you so much for joining us on this uh, discussion today. I just want to apologize in that we actually did have this discussion last night with some of the people who joined us on the live meeting. And unfortunately, the recording of that got corrupted. I couldn't upload it to YouTube, and I also couldn't play it on any media player. So I'm not really sure what happened with the recording over there. So unfortunately, I'm just going to go through the session that we had and the teaching material, but it's not a live session. It's just me talking. Um, but hopefully you'll still be able to get something out of it. So cover the basic things that I covered with everybody yesterday, but it might be a bit shorter than we spent about 40 minutes discussing it yesterday, so it might be a bit shorter on just me on my own. Um, but hopefully you'll be able to learn something. Okay, so as we were discussing yesterday, we were discussing last week, we had discussed a patient with metabolic acidosis and a high iron gap. So we were going to look at a new blood gas and figure out what we were dealing with today. So this is the type of patient that we often see in our settings in South Africa. 45-year-old female, presents with fatigue, confusion, abdominal pain, and a history of chronic diarrhea. Because of the heavy burden of HIV and immunosuppressed patients, we do often have patients who present with chronic diarrhea. Those who are not, it's not, of course, not the only cause of chronic diarrhea. I'm not saying that. I'm just saying in our setting, we often see it. So that's why I decided to go with the patient like that. So, this type of a patient who presents with fatigue and confusion, abdominal pain, and with this history, somebody that you would do a blood gas on immediately because you want to see what's going on. We covered the indications for it last week, but in this case, we would be looking at the possibility of this patient going into renal failure, this patient having electrolyte imbalances and things like that. So that's what we're trying to check for from the, is she acidotic? Is that why she's confused? That's what we need to get into. So that's one of the main indications for doing a blood gas in this case. Now, her initial vitals, we note that she's a bit dehydrated, BP is a bit low, the heart rate's a bit high. So if you were to go to the shock index calculation, you'd actually find that you were a little bit tending towards hypovolemic shock over here. The respiratory rate is a little bit high. Temperature is more or less within normal. And the initial labs that we get back are sodium that's within normal, chloride that's slightly low, and a bicarb which has decreased, which is quite indicative of chronic diarrhea, which is something that you do see sometimes. The bicarb tends to go down as they pass, and of course, your potassium does go down as well. So let's go on to the blood gas itself. And we ended up having a pH of 7.31, which is acidotic, although not to a great extent, but it definitely is acidotic. And the patient has started to going to a bit of acidosis. And we know our bicarb already. Our bicarb is 16. So as I was discussing with them yesterday, and just put it again today, we remember that bicarb, the movement of bicarb mirrors the movement of the pH. So as our bicarb decreases, let's just put it decreases, then our pH also decreases. So in other words, as our bicarb decreases, our patient becomes more acidotic as compared to carbon dioxide, which is a base, which is an acid, as it decreases. So in other words, as we get rid of carbon dioxide, our pH increases. So it's an inverse relationship. In other words, the more acid, carbon dioxide we have in our body, the more acidotic we become, and the less we have, the more alkalotic we become. So in this case, we see that our patient does have an acidosis, but has a low CO2. So that means this is a compensatory decrease in the carbon dioxide. So this patient would be somebody who's blowing off a lot of carbon dioxide. So you'd either find the patient having rapid, shallow breathing or very deep inspiration and expiration in an attempt to get out as much carbon dioxide as possible. Now, the body is very good at getting rid of carbon dioxide. So when your patients go into metabolic acidosis, which is more common, metabolic acidosis and metabolic alkalosis are more common than respiratory acidosis and respiratory alkalosis in general practice. But your body is much more capable of getting rid of carbon dioxide or holding on, well, not necessarily holding on, but getting rid of carbon dioxide to try and compensate. And for those of you who have been working in emergency departments, you'll notice it in your patients who are in renal failure, who are in diabetic ketoacidosis, for example, or anything like that. You'll often notice that shallow breathing or very deep in and out breathing, like Kussmaul's, to try and get rid of carbon dioxide. And for those patients who are in respiratory failure and respiratory acidosis, the body takes a bit more time to actually compensate from the metabolic side, but it does happen. But it's very likely that if you get a patient in metabolic acidosis, you'd often find they've already started compensating from the respiratory side. But if you get a patient in respiratory acidosis, you may not get much of a metabolic compensation by the time you get the patient, especially in an emergency setting. And as the time goes on, then you would find that it actually changes. So we had discussed the anion gap last week, and we're just going to look at it again. So if we remember correctly, it's the combination of chloride and bicarb, the two values, and then sodium minus that. So if we just go back to our values here. So chloride, 110, bicarb of 16, so 126, and sodium minus 126. So let's just put that there. Oops, sorry about that. Just went in the wrong direction. So let's just do it here. So we've got our sodium, which is 136 minus, just put brackets here. Sorry, try and get it up properly. So we said our chloride, which is 110, plus our bicarb, which is 16. Right. So just for the sake of putting it into an equation so that we have it. So what we actually have is 136 minus 110 plus 16, which is 126, which is equal to 10. All right. So we've got a normal anion gap. So you would expect in these circumstances to go into a normal or low anion gap. As your bicarb would drop, you would expect yourself to go into more of a low anion gap, metabolic acidosis. But essentially they are the same. There's some slight differences, but they are essentially the same. So now that we've decided what's going on with the patient, let's just have a look at what causes it. So the most common causes that you would see, especially in an emergency department, would be chronic diarrhea, renal tubular acidosis, and early renal failure. Now, this doesn't mean these are the only causes. I'm just saying in an emergency situation, these are normally the causes that we see much more often than any of the others. It's not an exhaustive list. There are other causes that you would lead to these as well, but these are just some of the more common ones. So this is not to say that you don't see the other causes, but in an emergency situation, these are the three that you would keep an eye out for. And then, of course, patients who have had an ileostomy, those who are maybe on carbonic anhydrase inhibitors or have been given excessive saline. Yesterday, we had quite a long discussion about the use of normal saline, but we won't get into it today. I'm hoping to have a proper session with you guys to discuss IV fluids and their use, as well as renal tubular acidosis, the types, how it happens, and why we get renal tubular acidosis. So hopefully we'll have that in the future. And then let's just look at the management. So the treatment is generally quite easy. You treat the underlying cause. So in this case, dehydration, electrolyte imbalances. If there's renal causes such as renal dysfunction, you may have to adjust medications. And it's an important thing to remember, especially amongst junior doctors. I've often noticed that when patients do have renal and hepatic impairment, there seems to be a tendency not to adjust the medications when you see the patient, let's say in an outpatient basis or clinic basis. It's important to remember that if your patient does have renal dysfunction and does have hepatic dysfunction, we live in a wonderful age of technology. It takes you just a second. You can excuse yourself from the room if you're embarrassed to do it in front of the patient. Go and check. Does this medication that I'm using affect the renal function of the patient or the liver function of the patient? And if it does, do I need to discontinue? Are there alternatives? Do I need to adjust dosage? Things like that. So yesterday I'd given them a very common example, which is metformin, which does affect renal function and is so commonly used in South Africa amongst diabetics. Well, across the world, it's used in diabetics. And it has quite a major impact on renal function. And I've often found over the many years of working now that it often receive patients in renal failure who've been seen at outpatients departments and clinics and district hospitals, and you'll find them on metformin like 1 gram TDS, and their renal function is it's terrible. But for some reason, they've been kept on these medications, patients with severe liver dysfunction being kept on some of the, anti-epileptics and paracetamols and things that affect liver function. So it's not to say that the patient necessarily needs to be taken off, but does the patient need dosage adjustments, things like that. And there are dosage calculators as well. So it's important to, my apologies, I'm just dealing with a bit of a post-nasal drip, so my apologies if my voice sounds a bit straight. Yeah, so you need to decide, am I adjusting the medication or what am I doing? And it's a very important thing to do. And then, of course, you need to correct the acidosis as it's there. We administer bicarb in case of severe acidosis. And for those of you who were with us last week, we use bicarb according to the rule of sevens. That's the easiest way to remember when to use it. So it's when your pH is less than 7, or your potassium, sorry about that, or your potassium is greater than 7. So those are the two times that I would suggest that you use bicarb, even if you're in a situation where you maybe don't have a senior to assist you or anything like that. It's a good time for you to start it. As we had mentioned the last time, and I discussed it in quite a bit of detail, how you go and administer it, the dosages, things like that. So if you would like to, please go back and watch that video. It will give you quite a bit of insight into the use of bicarb, but it has been associated with higher mortalities, morbidities, especially for patients once they've left hospital, or the mortality before exiting hospital and things like that. So these are the two circumstances where we use it and where it has come in handy. And of course, like for instance, patients such as this may have potassium deficiency with chronic diarrhea. And so it is something important to remember, that you should adjust and try and rectify whatever electrolyte imbalances there are. And then it's just monitoring of the blood gas, electrolytes, renal function, and of course, any comorbid conditions that the patient may have as well. So these are the important things that you need to do for these types of patients. Just want to see, no, this is the last one. So there was one, I just want to try and, let's just try and pause the share here. I actually just want to try and, sorry about that. I actually just want to bring up one other thing that I had showed them yesterday. I'll share the screen in a second. I actually just want to get to the website. Okay. All right. Let me just get you guys back on here. Sorry about that. Let's just get a new share going over here. All right. Okay, that should bring it up. So as you know, I've set up this emergency department assistant website for you guys, so that you can use it to try and figure out certain things. So I know some people have been using it, and thanks to those who have been using it. For those who haven't been using it, it's edassistant.netlify.app, and it's on the YouTube page, the link, and it's on the groups as well. But I just want to take you through to the blood gas calculator. And remember, this does work on phones as well and tablets. So it's quite an easy thing to use. I've got quite a bit in here for you guys. So this is under the adult section, not necessarily the research section, but just the adult section. So this is an ABG assistant. So it assists you at times where maybe, you may not be 100% sure of what's going on and may need some assistance. So I'm just putting in the values for our patient. Sorry, just to give you an idea of how it would, for example, guide you along those. Sometimes you may not have all the values, like in this case, I didn't have a PO2 and FiO2. But it would work if you had those. And it's quite easy. You just press analyze and it tells you what's going on. So it's a metabolic acidosis. Sorry about that. And it gives you the possible causes as well. And let's take another example just so that you can see as well. So let's say we have 6.8. Let's make it a respiratory acidosis. That's quite severe. 1.9. Let's make this 27. And then we can analyze that. And you can see it's got a mixed acid-base disorder. So it will tell you more or less what you're dealing with there. Oh, sorry. Let's try one more. Let's put this at 10.9, for example. And we can analyze again. And here we've got respiratory acidosis with the compensatory metabolic acidosis. And it gives you some examples of what could be going on. But we will discuss more and more of these ABGs as I come across them. And hopefully it will assist you guys in learning about the problems that you can encounter with ABGs. These two that we've done are relatively simple, and we'll do more and more complex ones. But thank you so much for joining me on the session today, and hopefully we'll have another one soon, and I hope you learned something from it as well. I just want to they did sorry, yesterday they did fight with me because I didn't show them the I didn't show them the joke properly. So I'll just share the joke that we had at the end of the session, just so that you can also have a look at it. There we go. So please, no offense to any surgeons who are out there. It's just a little joke to finish off. And yeah, I hope to see you guys again soon. Apologies for the voice. Like I said, just dealing with a bit of postnasal drip there. But hopefully we'll have another session soon. Okay, keep well, everyone. Bye.